Hello and good evening. I'm Melissa Idris. Welcome to Consider This. This is the show where we want you to consider and then reconsider what you know of the news of the day. Brain drain of the healthcare workforce, both in terms of international migration and also from the public to the private health sector. It's neither a new problem nor one specific to Malaysia. But after years of piecemeal measures hoping to address the underlying issues that lead to healthcare brain drain, what needs to be done differently? Joining me now is Professor Datuk Dr. Adiba Kamarul Zaman. She is the former Dean of the Faculty of Medicine at University Malaya. Dr. Adiba, thank you for joining me on the show today. Your recent tweets. Well, you recently tweeted a thread in which you said every year at least 30 of UM medical graduates choose to undergo houseman training in Singapore instead of Malaysia. And those tweets, Dr. Adiba, reignited the discussion on brain drain in healthcare, I think to the point of prompting responses from both the Minister and the DG of Health. So before we get into those responses, I want to better understand the issues as someone who is outside of the medical profession. The issue of brain drain seems to me one that is a long-standing one in the healthcare sector. But what have been the consequences that you've observed because of this issue, particularly in the past couple of years, in these pandemic years?
Mm-hmm. Well, thank you, Melissa. Where do I start? As you said, it's not a new problem. And we can divide it, as you rightly pointed out, into what we call internal brain drain, which is, specialists, usually at the specialist level, people moving from the public sector to the private sector. And that's a big problem here in Malaysia in the last 3 decades. 2.5, 3 decades, and then the external brain drain to higher income countries. Now, in a nutshell, what this does is, of course, deplete the public health sector of the much needed health workforce. And I must say that we shouldn't just focus on doctors. We have an equally large issue with nurses and to a lesser extent, allied health professionals. And when that does, obviously, it's going to affect public health services, which cater for the majority of the population. There's this mantra within our circles that 70% of specialists serve 30% of the population, right? So that's one aspect of it. Of course, it's a huge aspect of it. The second is, of course, where people don't think as deeply about it, is that who is going to be left to train the next generation of doctors? And this is particularly so when mid-level and senior specialists leave for the private sector. And what this is going to do in the long run is affect the quality of training of not just medical, junior medical doctors in medical school, but in the long run, specialists as well, who then go out to serve both the public and private sector. So this has a knock-on effect because medicine is an ecosystem that you kind of train the next generation and the next generation.
But may I ask, so since you brought up the kind of the different generations, how would a aging population, as we know Malaysia is set to become an aged nation soon, how does an aging population then complicate matters or provide an extra burden to the system?
Mm-hmm. So from that respect, because an aging population live longer, and we know in particular in Malaysia, they don't necessarily live longer better, which means they need more care. They have more health issues. They require frequent hospitalizations. They require frequent visits to doctors. So naturally, you need more healthcare professionals to look after an increasing aging population.
So Sorry to interrupt, Dr. Adi, but you laid it out for us in such a matter of fact way that it makes me think this is not an unknown problem. It seems to be quite clearly laid out what the issues are, what the consequences are. Is there an understanding of the underlying causes of the problem that leads to brain drain in healthcare professionals? Are we aware of where the maldistributions of the workforce are, where the understaffed, underpaid, overworked, underfunded issues within the system are? Is it clear to the policymakers in charge?
Yeah, so like you said, this is a long-standing issue, and there have been many factors which I think have made it a lot worse in recent years. So, like I said, with the expansion of and privatization of healthcare, that was the first wave of the internal brain drain that continues to deplete us of, like I said, mid-range to the super specialists into the private sector, and then these are the very people that we need to remain in the public sector to train the next generation of junior doctors as well as specialists. So that's number one. Number two, although I said, the 30 medical students from actually this has been going on for a very long time as well. But what seems to be happening in the last 5 years or so is the migration externally and also into internally, but into non-healthcare profession, are the junior doctors, are the medical officers who, are the ones that bertungkus lumus during the COVID pandemic, because they are the backbone of the public health system. And what has made it very, very acute in the last 5 to 10 years is a large production of medical graduates as a result of an expansion of medical schools, both public and private. I'm sure you've heard of this phenomena as well. But because there are not enough posts in the governments, in the public system where they need to remain as housemen and as medical officers initially for that training, because there's not enough of these posts. So you get a clogging of the system. So you hear of medical graduates, including medical graduates from and other public schools, waiting between 6 months to 18 months in the past to get this housemanship position. That in itself creates a problem because they come out of medical school and the housemanship years are critical to them then turning the knowledge and skills that we gave them during the 5 years as medical students to become real functioning doctors. And when there is a gap, then the reskilling has to happen. So that's one, the overexpansion of and lots of parents wanting to send. So if there's not enough places in Malaysia, they send them to Indonesia, they send them to Russia, they send them to Egypt, and wherever that would take them. And that's the issue of quality. That's another question, another issue. So because there's not enough posts for these medical officers to absorb the 3,000 or so that's produced locally and another 3,000 that's produced overseas, then you get this clogging, this traffic jam, which then the MOs then cannot progress. The houseman cannot enter into the MO position. The MOs, don't have jobs. To be fair, the Ministry of Health has been working very hard over the last few years, and YBKJ, and during his role as Ministry of Health, together with JPA and all that, created some more contract posts last year and the year before. But A, that's not enough, and B, the contract posts are rather will not cater for the duration of time that is required for them to undergo training to become specialists. Right. So all these frustrations then lead to people seeking better opportunities, better training pathways.
Is there a simple solution? I know no problem can be resolved simply, but is there a way to unclog this backlog that you talked about that allows to address this specific problem of contract doctors leaving because they feel a lack of opportunity or a lack of proper training or a career pathway? Is there an easier solution than one that's already on the table?
Yes, so as you alluded to, there needs to be an urgent solution as well as a mid and long-term solution. And I think that urgent solution is obviously, firstly, more posts. In my view, it can an issue. I think the government is very worried about the pension bill, and in a way, contract posts are okay, but it needs to be long enough that the medical officers can see through their training, because 3 years is not enough. So a minimum of 6 to 8 years if they're going to go on to become super specialists. So that's one, more money, more posts, right? But secondly, I think within the system, we can have a better training system that balances service with training. One of the difficulties is for the Ministry of Health is in placing these medical officers into posts to provide service for the public, but at the same time, they can undergo training. Which is what should and must happen. So I think if we work together between the Ministry of Health, Ministry of Higher Education, JPA, Ministry of Defense, everyone, and even the private sector, private hospitals, if we all work together I think it's still possible to create more training posts whilst waiting for the government posts, so that we can help unclog the system. So we need to have a more systematic national specialist training program that will make it clearer for our medical officers where the training exists, where do they go for the next 4 years for their training. I think that is definitely doable. I hate to blow my own trumpet, but in the last few years of my years as dean, we wanted to improve and strengthen the local master's training program and harmonize it with the program that Ministry of Health has called the Parallel Program, and harmonize it into one national training program that can help clearly map out where people go and work together between the university teaching hospitals and the larger Ministry of Health, to make it more systematic, to make it more, more systematic for our junior doctors. Yeah.
Are you seeing any encouraging signs coming up from the Ministry of Health to address the problem? I mean, in response to your tweets, the DG of Health said that there's no guarantee migration would stop, even if the issues of poor working conditions or bullying or low wages or lack of career opportunities, even if all those issues were addressed, there's no guarantee that brain drain would be plugged. Are you seeing any signs that show there is a movement to address this?
To be honest, what got me really concerned was, yes, people will go out regardless, but not in the kinds of numbers we're seeing. And what really perturbed me a little bit more was that we have signed an MOU with the UK government for our medical officers to go over to the UK, ostensibly to be trained, but how many of them will come back? Even if there is an agreement for them to come back, the salary is going to be greater. 3-month salary can pay off whatever bond, unless we put in like footballers a million bond. Which reminds me, I have already said in the past that private hospitals that steal our doctors should pay like footballers, right? And bankers. You pay, you compensate, and pay for the next person to be trained. But
That's one way of looking at it. Dr. Adiba, thank you so much for speaking with me today. I appreciate your time. That was former Dean of Faculty of Medicine at University of Malaya, Professor Datuk Dr. Adiba Kamarazaman. We're going to take a quick break here and consider this. We'll be back with more on this topic. Stay tuned. Hi, welcome back to Consider This. I'm Melissa Idris. We're continuing our conversation about brain drain of the healthcare workforce, both in terms of international migration and also in terms of from the public sector to the private sector. Joining me now is Dr. Murugaraj Rajaturai. He is president of the Malaysian Medical Association, also president of the Commonwealth Medical Association. Dr. Muruga, thank you for joining me on the show today. The MMA recently released a statement highlighting what it called, if I may quote the statement, a deep frustration with the system as the main reason for brain drain in the healthcare sector. I was wondering whether we could begin our conversation there. If you could elaborate what you meant, what MMA means by this deep frustration with the system.
First, good afternoon, Melissa. Thank you for having me. Yeah, yes, MMA, we gave the statement as deep frustration. Doctors who really are working with in the system, they will understand, but when from outside, it doesn't look like that, But let me start. The frustration starts from the houseman. So when you go in as a houseman, there is a lot of bullying. You can't sweep that under the carpet. So from the bullying part, the housemen have to go through all these. And for me, the housemen are exploited because they have got a lot of working hours, which are, say 7 to 5 is their working time, but their consultant wants them to come in. Some consultant want them to come in at 5 o'clock in the morning. And you go only when you finish your work. That might be 8, 9, 10 o'clock. These hours are not accounted for. And that's daily basis. So there's, of course, the houseman can't take the stress. It's a training period for him. So from the houseman, next thing you go as a medical officer, you go as a contract doctor. Contract doctor, what do you want to do? You want to go in as a permanent doctor, you want a career pathway, but only about 40% of them who went for the interview last year who got the permanent post. The selection criteria for permanent post is not so clear. The selection criteria for a promotion also is not so clear. So these things must change. And then when you become a specialist, it doesn't stop. Recently also, we've got so many complaints from specialists writing to us saying that they've been stressed out by their senior specialists or their consultants. So it doesn't stop. So it's becoming like a very toxic environment for doctors to work in the hospital.
Dr. Muruga, can I ask you, are the best practices that apply, the best practices of human resources that apply in almost every other workplace setting, is that impossible to implement in a hospital setting, in a medical setting?
Okay, so it's a question that I'm very happy to answer because I am writing to the Human Resource Minister about this. I want the JPA to sit together with the Human Resource Minister and sort this out because housemen are working and they're exploited. See, the thing that you asked me, you are looking into every other sector. The human resource is looking to every other sector and say you only can work so many hours. If you work this, you have to get your OT. You work Sundays, you have to get your extras and all that. But here for a houseman, there is a allowance 600. I think it's 600 ringgit a month as an allowance, and that is because your timing is 7 to 5 or whatever. But a lot of hours are unaccounted. Maybe some people tell me that they got about 6 to 7 hours a day, which is not accounted for. Let me give you an example. I got a niece working as an intern in Ireland. So they pay you for your nights. They pay you for every Saturday, Sunday, they pay you extra. So one day I told my niece, hey, you work all the Saturdays, you don't have to go tomorrow. She said, what am I going to do? If I go there, I get money, I can work. What am I going to do in the house? But they are going because they are being paid accordingly. So down here, we are not giving them that. We are exploiting the housemen. It's a big word that I'm using, but this is what I'm going to write to the human resource manager, a minister, and we have to sit together and try
Right.
to sort this out.
On that note of, looking at it from a human resources angle, you pointed to bullying a little bit earlier. Bullying happens in a lot of industries, but there are clear workplace guidelines to stop that kind of harassment. Is there a specific culture of fear that permeates the healthcare system?
Melissa, this thing that you said, it should apply to all the sectors. Whether it's healthcare or any factory, anything, the work bullying, it is there. But the environment in the hospital, you see, we are already stressed. We are dealing with life. So the junior doctor to the senior doctor is stressed up. So the culture has been like that. I don't know why. Maybe from those days, okay, I got bullied, then I bully or what, I don't know. But I'll give you another example. There was once when I was a medical officer, I was walking with my consultant and the houseman into ICU. I held the door open for the consultant and he came and held the door. I said, Naman, I hold. He said, no, no, no. In UK, we treat everybody as colleagues. I think that must change here. That must change here. That means we have to look at everyone as a colleague. We cannot look at them as junior doctors, housemen, seniors. No, that has to change.
All right. You talked about the different challenges at every kind of level of the profession, houseman, contract doctors, up to specialists. Where are you seeing the biggest leak in the medical talent pipeline? The reason I'm asking is that, is this known? Is this known to policymakers where we are seeing our talent drain out from the workforce?
Okay, if you take the healthcare sectors, it's draining from every level. For housemen, when they can't take the stress, some of them go through depression, this, that, they leave the system. Once they leave the system, of course, they cannot be a clinician, but they will leave the system and go into research or go into teaching, and some go overseas to do MBA and go into admin line. Medical officers, if their degree is recognized overseas, they will leave because we can't beat their pay. So, and when they, of course, we cannot beat the pay, but if we make their place more comfortable, they also wouldn't want to leave their family and go to a new place. See, Ireland now, in Ireland, even if your degree is not recognized, but if you have worked 2 years of your housemanship, they take that as a training and you can go there and work without sitting for any exams.
The way the public health sector treats the healthcare workforce versus the private healthcare sector, what is it just a matter of resources and funding?
Yeah, it can be resources. The main reason might be resources, but also again is the culture of bullying. That must change. You cannot. Actually, MMA is going on a roadshow to do this program called Train the Trainers, so that we can make the specialists and all understand that the junior doctors can't take this stress and they need a better environment. So we will be going on a roadshow. We are actually it's in the pipeline right now.
Okay, wonderful. So, on that note, then, Dr. Muruga, what are the changes? What are the changes that are needed to make a material impact on in addressing the well-being of the healthcare workforce, particularly young doctors who, the system kind of depends on their well-being, them wanting to remain in the system. Beyond the roadshow, what are the changes that you are hoping the new health minister implements?
Okay, actually, we had a meeting with our YB, Dr. Zaleha, the health minister, and first thing she told us that she's going to try to give us this year more contract doctors, give more permanent posts. Last year we got about 3,000 something, and she said that she will try. I can't mention the numbers here yet, but she said she's trying her best to give us more this year. And I can see that she's got the will to help us, with the reforms that we want. And the first thing is, of course, we must stop the bullying. Second thing is the selection criteria for contract doctors going to permanent posts. It should be transparent, because now when I apply, I go for an interview, I don't even know why I didn't get and why my friend got it. So the selection criteria should be better, and even for promotions. So senior doctors are leaving the public and going to private because of frustration. I'm a specialist, but I still can't penetrate the system. So they are also leaving. So funding might be the issue, but also maybe for now we might not be able to change the funding, but we can change the culture in the workplace. We can make it a better place to work. I mean, if I'm going to work, Melissa, with unhappy, stressed out, I don't want to go to work, I can't do my best. I can't
Understood.
I can't work with my team as well.
Yeah, it applies to all of us, but even more so for doctors who are dealing with life and death situation. Dr. Muruga, thank you so much for speaking with me today. That was Dr. Muruga Rajathurai from the Malaysian Medical Association, wrapping up this episode of Consider This. I'm Melissa Idris, signing off for the evening. Thank you so much for watching, and good night.